Okay, well, welcome. This session represents the first of a 2.5-year cycle. So I really want to start at the beginning. And the first thing I want to go over is, how is an injured patient different from a medical patient? All surgery patients really are injured. The injuries we make in the operating room, of course, have a good intention, but they're injuries to the patient nonetheless. And of course, we take care of many trauma patients and septic patients and burn patients who come with actual traumatic injuries. And I think we need to have a very good understanding of how the patient responds to these injuries. We'll talk in two parts here. There's a hormonal response to injury, and there's an inflammatory response. The hormonal response is sort of the classic response. The inflammatory response is more recently being understood, and I'd say that's where most of the trauma research these days is heading. This picture is just to drive home the point that there's a lot going on, and that many different organ systems are involved, many different hormones are secreted, many different cytokines are secreted. And although the goal isn't for us to make a catalog of what each and every one of these things does, I think the overall goal should be for us to have a big picture understanding. And so if the body has to respond to an injury, it needs to know that there is an injury. And although this may seem trivially obvious, it can be complicated. The most easily understood example, of course, is pain. If you've sprained an ankle or had a burn or broken a bone, one knows how much these things hurt. And that pain input goes directly to your brain, which localizes the site of injury, and the brain starts to marshal a certain response to this injury. Perhaps less obvious are the baroreceptors. Short of losing your airway, the thing that will kill an injured patient the quickest is intravascular volume depletion. And so there's a complicated set of baroreceptors or stretch receptors that are designed to detect this volume depletion. The most well-known ones are in the left atrium and the carotid bodies and the kidneys. Injured tissue releases cytokines. That's part of the inflammatory response we'll talk about in a little bit. But at high doses, cytokines are capable, at least some of them are capable of functioning as hormones. And so this is another input into the system. And lastly, there's the emotional response to the injury as well. And this is another input. These inputs have to make their way somewhere. And in general, they make their way to the brain, and in particular, the hypothalamus, which is the center that primarily deals with, more basic or more early sort of evolutionary type problems. And so after a signal is received in the hypothalamus responds to it and secretes a variety of different substances, some which go to the anterior pituitary and some to the posterior pituitary. The anterior pituitary is its own unique organ, but it has no arterial input itself. So it's a portal system. It's connected to the hypothalamus by veins, and the substances secreted by the hypothalamus will ultimately cause release of hormones from the anterior pituitary. For our purposes, in the trauma setting, we're only really going to be concerned about ACTH and growth hormone. The others, like thyroid stimulating hormone, are important, but not germane to today's topic. In the posterior pituitary, this is an actual part of the brain. So it's an extension of the hypothalamus. And so it's connected to the hypothalamus by neurons. And so products secreted in the hypothalamus travel down these neurons and await the appropriate stimulus for secretion. The only one that we're going to care about from the posterior pituitary in the trauma setting is ADH. A little bit about the hypothalamic-pituitary-Adrenal Axis, because this ultimately produces cortisol. And cortisol is critical for our very existence. And so once the appropriate inputs are received in the hypothalamus, of which there can be many, as we've just talked about, the hypothalamus will secrete corticotropin-releasing hormone, which makes its way to the anterior pituitary through that portal system and causes stimulation and secretion of ACTH. This system is regulated by glucose levels. So high glucose levels will shut this system down. In a non-injured or a non-stressed patient, ACTH release is circadian in nature, and the highest levels are late at night, and the lowest levels are first thing in the morning. However, in an injured patient, this goes out the window. There is no more circadian rhythm at all. And somewhat appropriately, the body responds to a proportional degree of injury. In other words, the amount of ACTH produced is directly related to the degree of injury. So a burn patient's producing a lot more than someone who has an elective lap chole, let's say. Ultimately, ACTH makes its way to the adrenal cortex and stimulates cortisol production. Sorry, this slide is so busy, but it does drive home the point that cortisol is really important. Cortisol, as we know, is absolutely essential for survival. If you lose your adrenals and don't replace cortisol, you will die. The major effect of cortisol is on host metabolism, glucose production. Cortisol secretion makes the host, the injured patient, become hyperglycemic. And we'll talk about the benefits of that in just a second. The other important action of cortisol is it makes other hormones work better, and specifically epinephrine and glucagon. And lastly, cortisol downregulates the inflammatory response. Clinically, that's how we usually use cortisol as immunosuppressive agent. And it might seem a bit paradoxical, since there's an inflammatory response to injury, why cortisol would downregulate this. But just like your car has a gas pedal and a brake, your body's response to injury has to have a similar kind of mechanism. Unregulated inflammation will be bad for the host. All right, so cortisol causes us to become hyperglycemic. It causes the liver to make more glucose. Where do the precursors for this glucose come from? Come from a variety of sources. We have a small amount of glycogen in the liver, and so that's part of it. But cortisol has a strong effect on skeletal muscle. And it causes protein breakdown of skeletal muscle, releasing amino acids. And many of these amino acids can be used as glucose precursors. Alanine is probably the most important of those, but there's a variety that can be used in that way. skeletal muscle also makes lactate. And so that can be used as a glucose precursor as well. And then fat breakdown is important too. Fat, the triglycerides cannot be converted to glucose. However, the glycerol backbone can be. So those are the sort of precursors for glucose production that will take place in the liver. And why is glucose so important to the injured patient? And we'll see that multiple other hormones also contribute to this hyperglycemic response. But we have a number of obligate glucose-using tissues, in particular the CNS, but also things like white blood cells require glucose as well. So we have to have this. It's down the road when we can switch over to ketones, but in the initial couple of days, you just have to have glucose. And so the injured patient makes sure that there's an adequate supply of glucose for the obligate glucose using tissues. Hyperglycemia also has a second sort of benefit to an injured patient. It increases serum osmolality. And so that will help mobilize fluid from the intracellular space into the extracellular and intravascular spaces. And that helps to support circulating volume. The other anterior pituitary hormone worth mentioning is a growth hormone. Growth hormone promotes protein synthesis, but not skeletal muscle protein synthesis. Overall, an injured patient is catabolic. They're in negative nitrogen balance. But there has to be some amount of protein synthesis that occurs. Coagulation factors and acute phase reactants and cytokines, these are all small proteins. They have to be synthesized. That has to be ongoing during injury because these factors are critical to surviving the injury. And so growth hormone promotes that type of protein synthesis, even though overall the patient is catabolizing skeletal muscle and sometimes even smooth muscle during this time. Growth hormone also goes to supporting the hyperglycemic effect. So it inhibits insulin release and decreases glucose oxidation. So all of these support hyperglycemia. And many of the factors that growth hormone is responsible for, many of the functions, are mediated by IGF-1, insulin growth factor 1. The posterior pituitary hormone that we'll be concerned about is ADH, or antidiuretic hormone, or sometimes even called vasopressin. It is synthesized in a couple of specific nuclei in the hypothalamus. And the primary stimulation for ADH release is increased plasma osmolality. There are sodium sensitive osmoreceptors located in the hypothalamus that detect this. And if the sodium concentration rises, indicating increased osmolality, ADH is secreted. ADH is also secreted in response to hypovolemia. And so baroreceptors that detect this also are an important stimulus for ADH release. The whole job of ADH is to promote water absorption. And this happens in the distal collecting ducts of the kidneys. If you ever take a look at the labs of one of your laparotomy patients in the first day or two post-op, you're likely to notice that their BUN is a bit on the low side. And that's primarily a reflection of the water absorption that's occurring under ADH influence. It also goes a long way to explaining why in the first 24 to 48 hours, it's hard to get our patients to make urine. I mean, when you're in the intern on call and you've got ICU patients, I'm sure you get charged with the goal of making sure all these patients are making enough urine, that they're peeing, they don't go into renal failure. And it can be quite a challenge to keep patients' urine output up because the hormonal environment says hang on to salt and water. So I think the moral of the story is you don't have to chase urine output too hard. You need some, none is never good. You need some, but if the patient's hemodynamically stable, not acting hypovolemic, going crazy with the fluid isn't a good idea because you're really fighting Mother Nature here, who's telling the body hang on to water. All right, so that's the quick rundown of the important pituitary gland hormones that are important in taking care of injured patient. Let's talk a little bit about the sympathetic nervous system. So the sympathetic nervous system primarily produces epinephrine. Norepinephrine is sort of a byproduct. It's not really secreted by the adrenal gland. Norepinephrine is basically a neurotransmitter in ganglia. And when the sympathetic nervous system is heavily stimulated, you get some sort of leakage of norepinephrine into the circulation. So it plays a role, but epinephrine is the primary product we're talking about, and is really the only catechol that's secreted in any meaningful amounts by the adrenal medulla. The peak elevation for epinephrine generally will be within 24 to 48 hours after injury. So these catecholamines have a variety of effects. We'll talk about the metabolic effects first. Again, all of these, or at least most of them, go to support hyperglycemia. So in the liver, glycogen breakdown is supported, gluconeogenesis is supported, fat breakdown is supported. Again, you can use the glycerol backbone of triglycerides to make glucose. Later on, those triglycerides will be involved in ketogenesis, but not right away. And again, in fat and skeletal muscle, the goal is to increase some fat breakdown. In skeletal muscle, we want to break down the glycogen that exists there. And importantly, we don't want skeletal muscle to be taking up glucose. And that's one of the major jobs of insulin, of course, is to stimulate glucose uptake in tissues like skeletal muscle and fat. And we don't want that going on at all right now. We're probably most familiar with the hemodynamic effects of catecholamines. They're certainly the most dramatic. And there's a variety of hemodynamic responses. Vascular vasoconstriction mediated by the alpha-1 receptors is critically important. We use drugs like Levofed for this purpose. Obviously, constricting the vessels on the arterial side will go to support blood pressure. And clinically, that's usually why we use these drugs. But the venous circulation also has smooth muscle and also responds to vasoconstriction. And in the injured patient, this is really important because about 2/3 of our blood supply exists on the venous side of the circuit. And so squeezing down on these vessels will increase venous return and get more blood back to the heart, so it can effectively increase circulating volume. Through the beta-1 receptors, catecholamines greatly improve the performance of the heart. So you get a higher heart rate, better contractility, better conductivity. All of this leads to increased cardiac output, which is valuable in the injury setting. Smooth muscle relaxation is mediated through beta-2 receptors. This is most important in the distal airways, and relaxing these distal airways allows for improved gas exchange, better movement of air in and out of the lungs. Catechols also greatly increase and stimulate certain hormones like renin and glucagon, and they inhibit insulin secretion. This slide is busy. We'll talk a little bit about the Renin-Angiotensin-Aldosterone system next. Renin is synthesized in the kidney, the part of the kidney known as the juxtaglomerular apparatus. It's under control of 3 different types of mechanisms. There's something called the macula densa, which is a chloride sensor. And so if chloride concentrations are decreased, renin is stimulated to be secreted. In the juxtaglomerular cell, that functions as a baroreceptor. And so if blood pressure is down or circulating volume is down, renin will be secreted. And lastly, renin is directly under the influence of epinephrine. And so if epinephrine is high, renin will be secreted. The whole point of renin here is to convert circulating angiotensinogen to angiotensin 1, and all this happens in the kidney. Angiotensin 1 is then converted by the angiotensin converting enzyme, which exists in the lung, and that's where we get the final finished product, angiotensin 2, which I'll just call angiotensin. This drug on its own is a very potent vasoconstrictor. It also has effects on heart rate and contractility. It regulates thirst. And the use that we're most familiar with is that it stimulates aldosterone secretion in the adrenal gland. So aldosterone is secreted by the adrenal under the influence of angiotensin, increased potassium levels. In the injured patient, ACTH is a very potent stimulus for aldosterone. So why is aldosterone so important? Its job is to help maintain intravascular volume by reabsorbing sodium. It does this in the distal convoluted tubule. If you absorb sodium, you're also absorbing water, okay? Because you're absorbing positive charges with the sodium, you have to eliminate, you have to get rid of a positive charge as well. So aldosterone also works to eliminate potassium and hydrogen ions as well. But the major role of aldosterone here is to absorb salt and water and support circulating volume. Glucagon, its job in life here is to support hyperglycemia in the injured patient. In sort of normal day-to-day metabolism, hypoglycemia is the major stimulus for this, but in the injured patient, it's the sympathetic nervous system. And again, the net effect in the liver is to cause glycogen breakdown and the creation of new glucose. Insulin is sort of the one hormone that we've talked about so far whose effect is shut down by injury. All the other hormones are ramped up to support hyperglycemia and other hemodynamic effects and circulating volume. But insulin's an anabolic hormone. It will have its day in a few days down the road when the patient sort of enters their anabolic phase. But in the first day or two of injury, these patients are catabolic, and they don't need what insulin does. Insulin promotes entry of glucose into specific cells, mostly muscle and fat. And so it supports the synthesis of glycogen and inhibits gluconeogenesis. This is not what we want in the first couple of days after injury. Interestingly enough, after about 24 hours, insulin production actually is increased. But hyperglycemia can persist for a long time. In a burn patient, it can persist for months. And so there's a peripheral insulin resistance that develops in the trauma patient, probably from a downregulation of insulin receptors. All right. So what did we sort of accomplish here, talking about the hormonal changes that take place in an injured patient? There's really three overall effects that are important. Hyperglycemia is important because it provides a ready source of fuel for obligate glucose-using tissues, in particular the brain. It has a secondary effect on circulating volume because the increased osmolality causes fluid shifts that bring fluid into the intravascular space. There are important cardiovascular changes that happen in an injured patient. These are mediated primarily by epinephrine and generally last 24 to 48 hours, certainly in the post-op period. As your patient makes a normal recovery, you will see evidence of this. For the first day or two, their heart rate will be 100 or so. By day 3 or 4, it's starting to drop down to a more normal level. And this just reflects that epinephrine has done its job and is now disappearing from the scene. The other major effect is salt and water retention, primarily mediated by ADH and aldosterone. And the job here is to support circulating volume. So these are the three major goals of the hormonal changes after injury. All right, let's talk a little bit about the immune-mediated response to injury. This, when I was starting out years ago, this was really never sort of talked about or understood. Now it's much more understood, but it's still an extraordinarily complicated subject that is, just beginning to have some clinical utility for us. The major idea here is that, there's been a change in how we think about the immune system. For a long time, it was felt that the immune system's job, and really its only job, was to distinguish self from non-self. That obviously works to explain the immune system's response to pathogens. Okay, the immune system recognizes something that doesn't belong, it marshals its resources, it takes care of the pathogen. But as time went on, it became pretty clear that the immune system wasn't quite as simple as that. First of all, there are some patients who had all the manifestations of a septic response with no organism detected. This could be seen in a multiply injured trauma patient. This could be seen in a burn patient. This could be seen in a patient with a bad pancreatitis. They have all the hemodynamic effects of sepsis, but there's no bug. So clearly the immune system has been activated, but seemingly not by any kind of organism. And then, of course, our body is full of bacteria, commensal bacteria, which our immune system does not react to. So the self versus non-self idea is a little bit simple. And a immunologist named Polly Matzinger sort of articulated these ideas in a pretty important article that was published in 1994. And her idea, her thoughts were that the goal of the immune system is to recognize danger. Danger can come from an external source, like a staph bacteria. It can come from an internal source, like injured or dead cells releasing substances into their environment that don't belong there. And it also takes into account that plenty of bacteria in our body are not dangerous and shouldn't be reacted against. The overall idea here is that in an injured patient, the inflammatory response that we see occurs as a result of what we'll call DAMPs, or damage-associated molecules, being released into the local environment. And these molecules activate the immune system, the innate part of the immune system, the natural killer cells, the monocytes, the neutrophils. And this reaction initiates a so-called sterile inflammatory response. So this is responsible for the elevated heart rate and many of the changes that we see in our patients after a trauma. And that these damage-related molecules, they react with the immune system through a variety of receptors called pattern recognition receptors. And it's binding to these receptors that causes the cytokine cascade that we also see when we're dealing with an infectious type of problem. So what are these damage-associated molecules? I mean, basically, they're endogenous molecules that become immunologically active once they're outside of cells. And so these molecules can get released, if a cell is injured or if it becomes ischemic or frankly dies. These cells spill their contents into the local environment, and the immune system is designed to react to this. I just talk for a quick second about a couple of these because there's a reasonable amount of research going into a couple of these. There's something called a high mobility group protein B1 that can be measured, and it's known to be rapidly released into the circulation very shortly after a trauma. It's a non-histone chromosomal protein, so it belongs in the nucleus of the cell, not in the sort of local environment. And its levels correlate almost exactly with injury severity score. So it can serve as a marker. And experimentally in animals, if you inject this type of substance, it causes fever, weight loss, barrier dysfunction, which just means cells swell up, and ultimately death. So really, many of these are the manifestations of a sort of septic type response. Another example is mitochondrial DNA. Again, this belongs inside the cell nucleus. This can be measured if you are so inclined. And in an injured patient, it has concentrations thousands of times higher than in a non-injured patient. It seems that this mitochondrial DNA causes extreme macrophage type activity, and at least experimentally injecting mitochondrial DNA into an animal model, again, causes a lot of the damage that you might see in a septic type patient. So from a cartoon standpoint, this kind of just shows what's going on. Tissue gets damaged. It spills, the tissue spills its guts into surrounding environment. These are some of the known ones here. Some of them, if you can read that, you might recognize S100 and heat shock proteins, things you may have heard about before, ATP. All of these things belong inside cells. But once they're outside cells, the immune system actually is able to recognize them. And that's what's being shown here. Antigen presenting cell can recognize some of these and activate T cells, for instance. So these things can cause the immune system to become engaged. I like this picture because it kind of shows the economy of the situation. We have two sort of circumstances. We have an immune system that has to recognize pathogens for sure, but it also recognizes internal dangers as well, internal threats. And at least interesting to me is that both the pathogens and the damage type molecules interact with the same group of receptors, these pattern recognition receptors. So we have sort of two sorts of problems, but really only one system. So there's a certain economy here. So from a design standpoint, seems pretty impressive to me. Once these receptors have bound their particular ligand, which whether it's a pathogen-related molecule or a damage-related molecule, the response is the same. Okay, you end up producing various cytokines and other products that are going to result in the immune response. And it's the same immune response, whether it's a pathogen or whether it's a bunch of dead tissue in a dead leg. It's the same response. So these pattern recognition receptors, again, we just mentioned this, but they're the same receptors that recognize external threats. So this goes back to that danger idea. Pathogens are dangerous. Dead tissue is dangerous. The immune system responds really identically. These pattern recognition receptors are significantly upregulated after blunt trauma. And the ultimate goal of all this binding is ultimately to lead to gene transcription and ultimately cytokine production. When I was going through medical school and residency, cytokines were the sort of the new kid on the block. It seems like, you know, every month or two, a new one was being discovered, and there was a lot of attention to learning about some of this stuff and what these things do. This is a more mature field now, but there's, you know, many different cytokines that have been identified. It's a difficult area to study because these things have a variety of functions and many overlapping functions. And so I imagine studying this is extremely difficult. But cytokines are very small polypeptides. They're active at extremely low concentrations, the picogram type level of concentration. And in general, they're designed to work locally. And so they deal with the local problem. Hormones classically work at a distance. One organ secretes them and they have an effect a long way away. Cytokines in general work in the local environment. However, there is some overlap, and in a very injured patient, there can be a lot of cytokine release. And so some cytokines, like interleukin-1, clearly have hormonal effects too, because there's interleukin-1 receptors, you know, in the hypothalamus, for instance. So the system isn't exactly cut and dry here. So the overall goal of all these different cytokines is to organize the inflammatory response to various infections and to actively promote wound healing in an injured patient. And that's why the inflammatory response is so important in the trauma patient, because once we get control of hemostasis and the immediate life threats are taken care of, the injuries have to be dealt with and fixed as well if the organism is going to survive. And this process really starts very shortly after the injury. All these cytokines, are able to react with very specific receptors, and so they all have very specific effects. The result of a cytokine binding to a cell is ultimately going to be some kind of modulation of gene transcription. In general, you're going to upregulate gene transcription, and so you'll get more production of whatever product that cell is supposed to be producing. I'll spend just a few minutes talking about some of the most well-known cytokines. And tumor necrosis factor was really the first one identified, the first one studied. As you might guess, it was first identified in tumors, and hence its name. It seems to be the earliest cytokine produced in the cascade, but it has an extremely short half-life. It's not around for very long. It gets stimulated, it's produced, it then activates the next cell down the line, and then seems to, get off the stage. So it's not around very long. It's produced by antigen-presenting cells like dendritic cells and monocytes and macrophages and some T cells. And its main goal is to get the cascade started. It oversees some pretty important functions in the immediate injury period. The injured patient is generally hypercoagulable. This is valuable, of course, to achieving hemostasis, perhaps not so valuable in a cancer patient, but in a trauma patient, at least being temporarily hypercoagulable is a good thing. And tumor necrosis factor helps to mediate that, and it inhibits anticoagulant pathways as well. In a cancer patient, long-term secretion of tumor necrosis factor is associated with muscle catabolism and the cancer cachexia that can be seen with temporal wasting. On the medical side of the equation, there are now some monoclonal anti-TNF antibodies that are really, really useful. Infliximab, which is primarily used to treat Crohn's disease and rheumatoid arthritis, has really changed the game for these patients. It allows them to get off steroids. These drugs are quite effective and don't have a lot of the debilitating side effects that prednisone will have, for instance. Unfortunately, in the trauma world, despite innumerable clinical trials of trying to give anti-tumor necrosis factor antibodies to patients who are septic, that doesn't seem to work. We haven't figured that out yet. And, primarily, I'm sure it's because in the patients we deal with, by the time we recognize that they're septic and want to give them an anti-tumor necrosis factor antibody, it's way too late for that. There isn't any tumor necrosis factor around anymore. But this remains some of the, kind of the holy grail in research into sepsis and stuff, is to try to find something that will halt the cascade. In animal models, it works as long as you give the antibodies before you make the animal septic. So in like a mice model, you can reliably induce sepsis with a cecal puncture. If you pre-treat that animal with anti-tumor necrosis factor antibodies, they don't get septic. But once they are septic, the antibodies can't reverse it. Interleukin-1 tends to be the, the next cytokine produced. Tumor necrosis factor is directly responsible from this. It stimulates macrophages and endothelial cells to release this substance. Again, in high enough doses, if the the injury is severe enough and enough interleukin-1 is released, then it has distant effects, hormone-like effects. The classic febrile response that we see post-op or post-injury is probably related to interleukin-1, which stimulates certain prostaglandin activity in the hypothalamus. But the hypothalamus has interleukin-1 receptors, so this sort of hormone-like response has evolved for interleukin-1. At very high doses, experimentally, you can give a patient presumably an animal model, interleukin-1 or tumor necrosis factor, and cause all the hemodynamic hallmarks of septic shock. So we clearly know that these cytokines are important in this process. And again, the sort of the holy grail in sepsis research is to try to interrupt this cascade. But so far, we haven't achieved that. A few of these others, and then we'll call it quits. Interleukin-2, produced by T helper cells after they've been activated. Where we've seen interleukin-2 used, or at least interleukin-2 antibodies, has been in the organ transplant world. Interleukin-2 has immunosuppressive effects, and so if you block that, it can be used in organ transplant. Not so much anymore, it has a lot of side effects, but once upon a time it was definitely used as an immunosuppressive agent in organ transplants. Interleukin-6 is sometimes used as a marker in research type ICUs that do a lot of work in sepsis and multiply injured trauma patients. This can be measured. Interleukin-6 really goes up in proportion to the degree of injury. And so some centers will use this as a marker of an inflammatory response type syndrome or a septic syndrome, and they will sort of follow this and try to correlate with the degree of sepsis that they are seeing. Interleukin-6 seems to be important in causing the liver to produce a bunch of so-called acute phase reactants. C-reactive protein may be the most well-known of those. And again, this can be measured and is often used as a marker of inflammation. There are a couple of these cytokines that work as anti-inflammatory agents. Again, a car has a gas pedal and a brake, so does the immune system. An immune system that is totally upregulated is potentially extremely dangerous. And so at the same time as all these inflammatory cytokines are being secreted, so are several anti-inflammatory cytokines, along with, of course, cortisol, which works as a brake in the system as well. I mentioned transforming growth factor beta because it seems to be really important in wound healing. There's even some wound healing agents that are sort of topical, transforming growth factor beta sort of preparations. So it's important in this regard and seems to have an important role in suppressing tumor growth as well. There seems to be a fair amount of research with this particular cytokine. And like I said, in the wound healing world, there's some agents that already make use of it. Nitric oxide, there's a lot of research going on in this drug. It causes vasodilation. And so It seems to be very important in the septic patient. As we know, these patients have decreased systemic vascular resistance, and that's thought to be related to excessive production of nitric oxide. And these septic patients are pretty unresponsive to drugs like Levofed. And again, the role of nitric oxide here is thought to be important. So there's some effort going on to understand this better and to see if there's some therapeutic role for maybe an anti-nitric oxide type agent. And this just sort of sums up the cytokine type situation. The inflammatory response is clearly important after injury. And there's innumerable agents. We've mentioned a few of the cytokines and nitric oxide. I didn't talk about prostaglandins, but they're clearly part of this process as well. There's just a tremendous amount of bench research going into understanding these processes. Eventually, bench research leads its way to developing therapeutics. We've already starting to see this with cytokines and various, anti-tumor necrosis factor antibodies. In the oncology world, there's seemingly a new drug every month that takes advantage of anti-cytokine antibodies as well. So more and more these things are becoming therapeutic, and I wouldn't expect that to be changing anytime soon. All right, well, that's it for this week. It's meant mainly as a kind of high-level overview to what is happening to an injured patient. Next week, we'll get into the weeds a little bit more. We'll talk about how a patient responds metabolically to injury, and then a few minutes about nutrition and, why and when and how with that. All right. Thank you.